Namaste, สวัสดีครับ Good evening, everybody. My name is Professor Ved Viprakasit from Mahidol University, Bangkok, Thailand. I'm going to give you a review on the new therapy in thalassemia plus for hydroxyurea and Luspatercept. And this is a part of the webinar on thalassemia and hemoglobinopathy management. I would like to personally thank my good friend, Professor Anuja Premahavana, for his kind invitation, and also to the Non-Communicable Disease Bureau, Ministry of Health, Sri Lanka, for giving me a great opportunity to be part of this very important program on the webinar and have a chance to sharing with you our data and our experience on treating patients with thalassemia. And this is my disclosure. So I'm going to give you an overall rationale for the new therapy in thalassemia, and also provide with some the update on the preclinical and the clinical studies of the novel agents, focusing on the hydroxyurea and Luspatercept. Globin, iron, and heme play a critical role in the red cell production. We can divide erythroid development into two different stages. First is the early stage erythropoiesis, which is we develop from the hematopoietic stem cell to the BFUE, CFUE, and pro-erythroblast. The second stage of erythroid development is terminal erythroid differentiation. At this stage, from pro-E, erythroid progenitor cell will further mature into the early erythroblast, late erythroblast, the reticulocytes, and red blood cell. Inside the red blood cell, you have a major protein, which is the hemoglobin, which is composed of the 2 beta-globin chain and 2 alpha-globin chain. And inside of that, it embedded with the 4 molecule of heme, which is linked with the iron, which is a very important element to carry the oxygen throughout the bodies. In these two stages of the erythropoiesis, the first part of the proliferation, maturation, and survival is under control of erythropoietin, and this process it usually lasts around 10 to 14 days. The second step of erythroid differentiation is iron dependent, and at this stage, we produce more and more hemoglobin in the cytosol of the red blood cell, and that's why we see the cytoplasm from blue to turn pinky and red at the end. And this stage usually around 3 to 4 days in the first part until become the reticulocytes, and another 1 or 2 days from the reticulocytes to become the mature red blood cell. In patients with thalassemia, because of the genetic defect leading to the globin gene mutation, because of the mutation in the beta-globin genes, causing a reduction of the beta-globin production, so you have excess of the alpha-globin, and this unpair of the alpha-globin leading to the erythroid pathology. It will precipitate in the erythroid progenitor cell, and that causes the consequences that we know as the ineffective erythropoiesis. And if these erythroblasts can survive and differentiating into the mature red blood cell, this unbound alpha globin in hemichrome compartment will precipitate on the red cell membrane. And because it contains the iron inside the molecule, it will cause an oxidative stress and leading to the red blood cell hemolysis. This ineffective erythropoiesis is a very major pathology in thalassemia. It leads to the intramedullary hematopoietic expansion, so that's why you see thalassemic phases in patients with thalassemia who do not acquire the appropriate treatment. The bone cortex will expand, making the shell become thinner, so it's not surprising, at some certain period of the time, the patient will have osteoporosis and osteopenia and fragile bone, easy to get fractured. And extramedullary hematopoietic expansion also observed, so that's why the patient have the enlargement of the liver and the spleen. And if you take the bone marrow from thalassemia patient out and looking at the microscope, you will see that the marrow activity is high. You see a lot of erythroblasts, but you don't see that these erythroblasts differentiating into the mature red blood cell. And that's the signature of ineffective erythropoiesis because it has a maturation arrest as the early pro-erythroblast. Because of this pathology, all the novel therapy are tackling at the different angle in thalassemia pathophysiology. So from ineffective erythropoiesis leading to chronic anemia, and this ineffective erythropoiesis send a signal now to the GDF11 and causing a low hepcidin level. And this low hepcidin level leading to primary iron overload. Chronic anemia making the patient become transfusion required. And of course, after a certain period of blood transfusion, patient will develop the secondary iron overload. And the most important factor, which is the origin of this pathology, is the globin imbalance. So there are three pillars of how do we treat the patient with thalassemia with the novel therapy now. First, we have to do the rebalancing the globin synthesis by the use of the gene therapy, genome editing, or hemoglobin F inducing agent. We can modulating ineffective erythropoiesis by using a new compound or new molecule, which I'm going to discuss in detail, especially erythroid maturation agent. There are several other agents that have been studied in thalassemia, for example, like PK activator or mitapivat, the JAK2 inhibitor, which had a paper published in Blood around 4-5 years back, and the glycine transport inhibitor, bitopertin, which I just published a paper in British Journal of Hematology a few months ago. Because of the interest of the time, I cannot cover them all. So today I'm going to focus on erythroid maturating agent. And the last but not least, as I mentioned, that the dysregulation of the iron, which is sequestrated in the erythroid progenitor cell, leading to the iron-restricted erythropoiesis. And if we can reduce this iron in erythroid progenitor cell, we might be able to improve ineffective erythropoiesis as well. So there are several clinical trials that we are currently doing in Bangkok, Thailand, using the hepcidin mimic molecule, the stimulator of the hepcidin production, such as the TMPRSS6 ASO, or we use the shRNA or the silane to inhibit the TMPRSS6. And finally, also the clinical trial on the ferroportin inhibitor. So all of this clinical trial, I will not have time to discuss with you today. And I hope that we can discuss about this in the near future. So today we focus on the how do we rebalancing the globin synthesis. In order to rebalancing the globin synthesis, it's a very basic concept. You don't have a very good beta-globin gene. Why don't we replace that with a new beta-globin gene? And this is a concept. And thalassemia was among the first genetic disease which gene therapy was proposed. And why thalassemia is such a very good model? And the reason for that is because, in thalassemia, it's the defect only in the globin gene. And because of the single mutation in one gene, it has the consequences on the several complications and morbidity. And if we can correct that, we should be able to improve the whole system of the patient. And this mutation is only affecting the hematopoietic stem cell system and specifically erythropoiesis. It does not affect myeloid or platelet at all. Second important reason is the stem cell transplantation is well developed for hematopoietic system. So if we can correct thalassemic stem cell in the patient, So we don't need any donor for the stem cell transplantation because we can do autologous. So we take stem cell from the patient out, correct it, and give it back to the patient. So there are several clinical trials on the beta globin gene therapy in the patient currently ongoing now in the US, in North America, in Europe. In Italy, there's a study which is the ticket beta tau by the, or we call the GLOBE study, which already recently published a very good data. And this is a study also in pediatric patients. And another study is the TNS 9.355. But the major milestone is from the Bluebird Bio or Syntico, which is they have a conditional marketing authorization for their autologous CD34 positive cell encoding the baby beta globin, which is become commercial available back in 2019. However, due to a recent report of the MDS and acute myeloid leukemia in sickle cell patients, the study have been held by the EMA and FDA early this year, in February this year. But just 2 or 3 days ago, the FDA just lifted the hold on this Bluebird Bio gene therapies. And this is just the news come out just 3 or 4 days ago. So because based on independent evaluation by the safety committees, it doesn't seem that one of the MDS doesn't seem to be a true MDS, and also one AML might not really related to the gene insertion. Because one of the complications that we really are afraid of is the insertional mutagenesis. You will hear more in detail from my good friend Sachi in his review on the gene therapy later on in this program. Besides putting an extra copy of the beta globin gene into the stem cell, how about we do the gene therapy in vivo by upregulating the expression of existing gene in the beta globin gene cluster? For several years, we have observed that in patients with beta-thalassemia, if they have increased or elevation of the gamma-globin gene, which is leading to increase of hemoglobin F, this gamma-globin will also bind to the free alpha to generate the hemoglobin F. So you have less free alpha precipitation. And you can imagine that the ineffective erythropoiesis will be much better compared to those patients who do not have upregulation of the gamma-globin expression. And this is just one of the clinical observations that if you counting the number of the morbidity in the patient who have the different baseline hemoglobin F, those who have higher hemoglobin F will have less morbidity score. So that's a several, for many years, that's a several study clinical trial try to upregulating the gamma-globin gene expression. The gamma-globin gene normally expressed in fetal DNA, fetal erythropoiesis. However, in the adult erythropoiesis, the gamma-globin will be closed or not expressing because of the suppressor, which is the major suppressor, is the BCL11A. And this protein is under control of the KRF1 and c-MYC. So when you got this suppressor, the gamma-globin genes will wrap up and hypermethylated. So the use of the several molecules is trying to modulate this epigenetic program. The hydroxyurea has a different mechanism. Hydroxyurea will leading to the cytotoxic stress in the hematopoietic stem cell. And this stress will cause an environmental selective advantage. To some of the hematopoietic clone, this has high propensity of gamma-globin gene expression. And this gamma-globin clone will predominantly expand after the use of hydroxyurea. And this is a summary of some of the hemoglobin F inducer, like the DNA methylation inhibitor, like 5-azacitidine or decitabine. However, there's still only few studies and also some of the adverse events that make it not really favorable in terms of the clinical use. As the use of the short-chain fatty acid, which again has a very small sample size and lack of the long-term efficacy data. Thalidomide and derivative has few studies reported from India. And again, they show a very good response in terms of hematological hemoglobin increase, but again with the small sample size. The erythropoietic stimulating agent like EPO might not really correct for thalassemic stem cell. It may be used as a combination therapy with the hydroxyurea. And the clinical response can be quite variable. So the only agent that have been widely used and in our clinical practice for many years is the hydroxyurea. It has been shown to have the favorable effect on the red cell hemolysis and hypercoagulability in disease. It has the favorable effect on the clinical morbidities and well tolerated. However, the data in the literature still very confusing. I did some review for Cochrane many years ago on the use of hydroxyurea as a reduction of the red blood cell transfusion in non-transfusion dependent thalassemia. And from our review, I conclude that there is no trial comparing hydroxyurea with the placebo. The effect of the hydroxyurea on transfusion frequency was not reported, and the overall quality of outcome reported was graded as very low. So when we look at the literature, the definition of the clinical severity of the patient might not exactly be the same. In some study, most of the study they call beta-thalassemia patient, beta-thal major, beta-thal intermediate. However, when you look very carefully, the transfusion requirement quite be variable. And some of the patients that they describe as beta-thal major, they are not indeed the beta-thal major. They might be, non-transfusion dependent beta-thalassemia, but appear to have received a regular blood transfusion. So in order to understand this, we're looking at our patient that we start a prospective cohort of using hydroxyurea. One of the very important points of our study is to define the clinical severity in the patient based on our current classification as TDT and NTDT. So we got 3 patients with beta-thal major TDT. We got another 3 patients with NTD beta-thal, which we used to call them as beta-thal intermediate. And we got 20 patients with beta-thal hemoglobin E. And these beta-thal hemoglobin E, we divide them to transfusion-dependent ETAL and non-transfusion dependent ETAL. And from our evaluation, patient with beta-thal major, there is no clinical response in terms of the transfusion reduction to hydroxyurea. For beta-thal intermediate, we observe some clinical response, which I will show you later on. For hemoglobin E beta thalassemia, similar. If the patient is transfusion dependent, there was no clinical response. While in the NTD hemoglobin E, we observe some good response and partial response. The good response we define as increased total hemoglobin over 1 gram per deciliter, and partial response is increased by 0.5 to 1 gram. And around 25% of the patients are non-responder. So the overall 75% of NTD patients show a clinical response to hydroxyurea. And this is the detail of our patient. In our 3 TDT patients, we cannot reduce transfusion requirement, but we can reduce the size of the liver in the patient, in 2 patients. Okay, so because they have been splenectomized, we cannot evaluate the size of the spleen. For the NTD patient, of course, we can reduce the size of the spleen, in one patient, we can completely stop blood transfusion. So again, this is like what I told you earlier, that some of the patients are not truly TDT. They are TDT who appear to receive blood transfusion. And in those cases, after use of hydroxyurea, we can maintain the level of hemoglobin up to 9 grams without transfusion. In another patient, we can reduce the size of the spleen. And a most important one, which I show you the picture, this is a 20 years old hemoglobin E beta tau NTD patient who has the color blindness. And when we evaluate by the MRI, we saw this extramedullary hematopoietic mass in the maxilla of the patient and causing a suppression of the optic nerve. So after 1 year, the use of hydroxyurea, the patient can gain the visual function, and also you can see the size of the EMH has significantly reduced on both maxilla. For patients with hemoglobin E beta-thalassemia who are NTD, as I mentioned earlier, around 75% are good responder and partial responder, and around 25% are non-responders. So we ask the question whether how can we predict those who might get response? And the only marker that we can observe in terms of the clinical demographic data is the baseline absolute hemoglobin F. Those patients who has low absolute hemoglobin F, such as 0.5, they will not respond to hydroxyurea. So I think this can be a very good, important clinical marker for clinicians when you decide to use hydroxyurea for patients with hemoglobin E beta thalassemia. We also are looking at some other hematological parameters for the overall of the patient who exposed to hydroxyurea. And this is the average data before, 6 months before and 1 year after the hydroxyurea treatment. We did not see a significant myelotoxicity after the use of hydroxyurea, and also the platelet count and some other hematology remain are benign. So there is no serious events affecting the hematology of the patient after the use of hydroxyurea. This shows you the good response to hydroxyurea. It's a continued efficacy. And also, we analyze the genetic determinants that related to the high propensity of gamma-globin gene expression, such as the G-gamma-globin promoter marker of the XMN1 plus, HBBP1, BCL11A, several SNP, and the CMIP SNP. So only the XMN1 and HBBP1 show a significant association with a good response to the hydroxyurea. And I think this can be another predictor when you decide to use hydroxyurea in patients with thalassemia. And some of these data, especially the XMN1, is echo the several previous studies from India and from Iran. So besides the pharmacological manipulating the gamma-globin expression, we can use the genome editing by removing the BCL11A binding sites. I think you will hear later on from the Saji lecture. And most exciting publication of this CRISPR-Cas genome editing just published early this year, and it can make a transfusion-free in one patient. So I think this is a very exciting era for the novel therapy for thalassemia. So finally, I'm going to cover another very important novel therapy by modulating ineffective erythropoiesis in the patient. Erythropoiesis is under control by the transforming growth factor beta or TGF-beta super family, and it acts to the SMAD pathway to control the cell quiescence, apoptosis, proliferation, differentiation, and also regulating hematopoiesis. In patients with thalassemia, because of the ineffective erythropoiesis, we have observed that there is a hyperproliferation and elevation of the SMAD2/3 ligand level. And this hyperproliferation of this SMAD2/3 signaling pathway leading to impairment of erythroid maturation. So that's why in the bone marrow, of patients with thalassemia, you see a lot of young erythroblasts, but you don't see these young erythroblasts to undergone terminal erythroid differentiation to become the mature red blood cell. So we can call this is the erythroid maturation arrest. So if we can block this SMAD signaling pathway by the use of the SMAD2/3 ligand trapping, we might be able to treating this impaired erythroid maturation and elevate the ineffective erythropoiesis. So we release the block. And this molecule of the ligand trapper is the Luspatercept or ACE356. It has a modified extracellular domain and it has the human IgG1 Fc domain. There are two major molecules. One is Luspatercept and another one is Sotatercept. So in the phase 1 and 2 study, both molecules has been shown to have an effective in terms of the transfusion reduction. However, because of the Sotatercept might have some consequences in terms of endocrinology, so this molecule has not been further developed for patients with thalassemia. Only the Luspatercept has several clinical trials in the phase 2 trial, the phase 3 of the BELIEF, and the phase 2 of the BEYOND that I will discuss, and also the another trial which I leading, which is in the pediatric, which is we start the recruiting early later on this year. In the phase 2 trial, which published in 2019 by Professor Antonio Pica, they analyzed the effect of Luspatercept in around 60 thalassemia, beta-thalassemia patients, 30 NTD and 31 TDT. The patient received different doses of Luspatercept up to 1.25 milligram. In NTD patients, 58% of them show increased hemoglobin over or equal to 1.5 gram per deciliter. And for transfusion-dependent patients, 81% of them they can show a reduction over 20% of transfusion requirement. And this picture shows one of the NTD patients from his study that have significantly improved the chronic leg ulcer after the use of Luspatercept, meaning that the patient has increased hemoglobin level and also improved the tissue oxygenation. The BELIEF trial is the randomized double-blind placebo-controlled phase 3 study in adult patients with TDT. So we compare the use of Luspatercept to the placebo in patients over 18 years of age who require regular blood transfusion and compare the transfusion requirement after the use of Luspatercept or placebo, and we follow them around first 48 weeks, and later on we have the extension period as the open label up to 5 years. This data published in 2019 of this phase 3 clinical trial in New England Journal of Medicine. Luspatercept achieved the primary endpoint. So we show a significant greater proportion of Luspatercept treated patients who can achieve over 33% reduction from the baseline in transfusion burden during the week 13 to week 24. And we select the 33% because this is a clinically significant if we reduce this amount of blood transfusion in the patient. So you can see 21.4% of Luspatercept arm compared to only 4.5% in placebo arm. In substratification analysis, in all overall patients who received Luspatercept compared to placebo, so in all subgroups also achieve the primary endpoint from different regions of the world, from the different age group, from the splenectomy or non-splenectomy, different gender, and also the type of thalassemia. But you can notice that the result in non-beta 0 seem to be a bit better than the beta 0. And also in terms of the different baseline transfusion burden or the iron burden in the patient. For the key secondary endpoint, so as you can see on this slide, the Luspatercept is significantly reduced the transfusion requirement compared to the placebo. when we looking at the different, for example, reduction over 33% from week 37 to 48, reduction over 50% from week 13 to 24, and reduction over 50% from week 37 to 48. So Luspatercept meet all the secondary endpoints. And also the reduction of the red blood cell transfusion burden during any 12-week and 24-week interval. Luspatercept also significantly reduced compared to placebo, and as you can see on this slide. In terms of the safety summary, there is no very important major signal comparing between Luspatercept and placebo. And in terms of the major treatment-related AE, the Luspatercept have more bone pain and also more arthralgia compared to the placebo and more dizziness. This is the data by looking at the iron burden after the use of Luspatercept. As you can see at the upper panel of the serum ferritin and the lower panel of the liver iron concentration and myocardial T2 star, the patient who received the Luspatercept has a higher proportion to achieve lower iron burden status when we follow them from 1 to 24 to 25 to 48, or even in the extension trial, and is continue to improve the iron burden. And this is also with the use of the iron chelation therapy. So Luspatercept have been approved by the US FDA in 2019 and EMA in 2020 to treat anemia in adult patients with beta-thalassemia who require regular blood transfusion. We are about to presenting the data in EHA this year on the randomized clinical trial of Luspatercept in NTDT patients, and this is the Beyond trial. So again, similar to the Believe trial, we use Luspatercept compared to placebo, but the primary endpoint is the proportion of the patient with increase of hemoglobin over 1 or equal to 1 gram per deciliter over a continuous 12-week interval from week 13 to 24 in the absence of transfusion compared to the baseline. And also, we developed the NTDT Pro as a questionnaire, patient-reported outcome to follow the patient, and you can find our publication in American Journal of Hematology. And I think this can be a very useful tool to evaluate the improvement of the hemoglobin and how they have consequence in terms of the quality of life. So in summary, the novel therapy for thalassemia include rebalancing the globin synthesis, modulating ineffective erythropoiesis, and reducing iron-restricted erythropoiesis. Gene therapy and upregulating hemoglobin F, both pharmacological and genome editing approach, are currently available and show a promising efficacy. Targeting ineffective erythropoiesis, especially the use of Luspatercept, provide a new target for thalassemia treatment. The activin ligand trapper, such as Luspatercept, is the first of its class of modulating erythropoietic drug and is seem to have a role on both TDT and NTDT. And finally, the several new molecules targeting iron regulation or generating iron deprivation in erythropoiesis are under development with some promising results. So thank you very much for your attention. And as you all know, we are in the hardest time of human history because of the COVID-19. So I wish you all to stay healthy and free from the COVID-19. Thank you very much for your attention. สวัสดีครับ